Hello and welcome to today's webinar, Community Benefits, State-Level Changes, Resources, and Working with Local Hospitals. Jennifer Mumm, a WSPHA board member, will introduce our panelists.
Thanks, Betsy. I also want to say thank you to Wasalfo, who is co-sponsoring this presentation with WSPHA. We had talked about kind of the need to and the desire to pull together a presentation on the topic of community benefit actually toward the end of the legislative session, and so thank you to Wasalfo for kind of helping a little bit on this topic as well. There's lots of information included in this presentation today, so just want to make sure that everyone knows that the presentation will be available on the WSPHA website. There'll be a recording available, and so if you want to go back and catch something that you missed or see slides in more detail, that will be an option. We have a great, very esteemed panel today, starting with Dr. Ali Thomas, who is a recent Mongan Fellow. So if you don't know what that is, it was formerly the Commonwealth Fund Fellow and Harvard University Fellow in Minority Health Policy. And he is participating today in that capacity as a Mongan Fellow. And in his day job, Dr. Thomas practices internal medicine at Group Health Cooperative in Tacoma, and he's also on the medical staff for St. Joseph Medical Center, but he's not representing either of those organizations today. Dr. Thomas's professional activities also include health policy advocacy for the American College of Physicians and community leadership training through Leadership Tomorrow Seattle. He received his medical degree from the University of Michigan in 2002 and completed his internal medicine residency in Portland in 2007. Later on the call, actually our second speaker is having to do a live interview at noon, so Representative Laurie Jinkins will be joining us later in the presentation. As most of you know, she's a legislator, attorney, and public health advocate with a long record of public health service. She was elected to the Washington State House of Representatives in 2010, representing the 27th Legislative District, which includes much of Tacoma. And she serves on the Healthcare and Wellness Committee, among others. She has served as the Deputy Director of the Tacoma-Pierce County Health Department and formerly worked at the Washington State Department of Health and for the Washington State Attorney General's Office. And then our next presenter is Dr. Megan Kay. Megan is a CDC Post-Epidemic Intelligence Service Practicum Scholar. She's stationed at Public Health Seattle and King County, and she's doing an extension of a Epidemic Intelligence Service Fellowship that she did here. She's worked at Public Health for 2 years prior to that and is currently focusing on assisting hospitals with the new IRS-mandated Community Health Needs Assessment and implementation strategies for community benefit. And she holds a Doctor of Veterinary Medicine from the University of California, Davis. And our final speaker today is a great partner. Shalene Whitaker is the Policy Director for the Washington State Hospital Association, where she's worked since 2004. She is responsible for a variety of policy issues ranging from the implementation of healthcare reform to mental health and federal policy. She also does work on initiatives and policy bills during the legislative session at the state level. And Shalene holds a Master's of Health Administration and a Certificate in Health Policy from the University of Washington. So we have a great group presenting today, and we will get started because there is a lot of information here. So Betsy, do you need to do any more explanation?
Yeah, I will do a quick overview here. Just to ensure best quality of audio and visual, you should exit from any application. And then secondly, this is your control panel. We will be accepting questions during the presentation through the questions box. So if you just type those in and send them to us, we will pose them to the presenters and send the answers back to you. And then lastly, as Jennifer mentioned, the slides and the recording will be available to attendees after the presentation. Dr. Thomas?
Well, thank you. Can everyone hear me okay?
Yes.
I'll assume that's a yes. So thank you for the opportunity to present to you. I became interested in hospital and community interactions while in residency. When I noticed the lack of African American residents, I actually started my residency in medicine and pediatrics at Rush and Cook County Hospitals in Chicago. And eventually I studied topics related to this through the Commonwealth Fund Fellowship in Minority Health Policy, now called the Mongan Fellowship. As already stated, I worked for Group Health on the medical staff of Franciscan Health System, but this research and my comments do not represent the views of any organization. So community benefit has several definitions, but essentially represents a social contract between hospitals and their communities to continue the original charitable services for which hospitals were first established in the 19th century. One definition of community benefit is unreimbursed goods, services, and resources provided by healthcare institutions that address community-identified needs and concerns, particularly those of people who are traditionally uninsured and underserved. Over the last 6 decades, the federal government has progressively institutionalized what is expected in this social contract. When the modern era of hospitals dawned with the Hill-Burton Act, serving the poor for 20 years was explicitly required of grant recipients. The IRS followed suit a decade later. Medicare and Medicaid were expected to obviate the need for charity care, so the IRS agreed to broadly accept community benefit activities. Yet regulatory changes and market changes created a new landscape. Most egregiously, wealthier hospitals actually turned away poor patients, dumping them on public hospitals, a problem that Congress did solve. But for 2 decades, the federal government did not weigh in as hospitals began to slip their traditional moorings, binding them to their local communities. This changed in the early 2000s. If you go to the next slide, please. This changed in the early 2000s when financial vulnerability to healthcare costs dawned on the national consciousness. A 2003 front-page article in the Wall Street Journal reported patients at Yale faced garnished wages, liens, and foreclosures and other aggressive debt collection. The public learned of the importance of hospital financial practices for individuals. Medical debt is the leading cause for personal bankruptcy, and hospital bills are the largest single cause for medical debt. A 2008 Commonwealth Fund survey discovered that 16% of Americans have been contacted by a collection agency for unpaid medical bills. 28 million had used up all their savings to pay medical bills. 21 million incurred a large credit card debt, and 21 million could not pay their basic necessities because of medical debt. Next slide. Okay, sorry. So in 2003, the American Hospital Association responded by asking its hospitals, its members, to voluntarily follow certain guidelines for hospital community benefit, and for billing and debt collection. The Access Project and Community Catalyst conducted a random survey of 99 hospitals, finding in their sample hospitals failed to encourage charity care. For instance, most did not provide detailed information about their charity care policies. We can be proud that all of our hospitals in Washington State have their policies posted on the Department of Health website. We also know exactly how much they spend each year on charity care. The next slide. But deciding how much hospitals should spend is muddy. A raw dollar figure is not meaningful because meaningful expenditures must at least be a ratio of two numbers. One approach is to expect a hospital's total community benefit expenditures to equal the value of its local, state, and federal tax exemptions. This is a high standard, likely attained only by public hospitals like Harborview, which accounts for 20% of Washington's total charity care. Nationally, half the value of hospital tax exemption would otherwise have gone to local and state governments. Little wonder state and local governments led efforts to regulate community benefits from the mid-1990s to the mid-2000s. Next slide. The federal response was led by Senator Chuck Grassley of Iowa and chair of the Senate Finance Committee, who held hearings on hospital tax exemption in 2004 and 2006, sent inquiry to the 10 largest nonprofit hospitals, pushed the IRS to reform its oversight, and drafted the legislation later integrated by the Accountable Care Act. The ACA reaffirmed a federal role in distinguishing not-for-profit from for-profit hospitals. Section 9007 has rightly been called the most important change in the accountability of nonprofit organizations in almost 70 years. Effective in 2010, hospitals must create and publish policies conveying who qualifies for charity care and discounted care, as I said, already established in Washington State. They can no longer charge insured patients rates far exceeding the negotiated rates they charge the insured, nor can hospitals take aggressive but legal collection actions without reasonable efforts to find alternatives. Next slide. In summary, hospitals meet their social compact by demonstrating very clear benefits to their communities. These include charity care and unreimbursed care for programs like Medicaid, health promotion and other services I will detail in my next talk, and other forms of support. What the IRS found most challenging, however, were those activities lawyers and the lay public don't ordinarily associate with health improvement. For IRS purposes, community building activities were never per se included under community benefits. They have a separate section. Obviously, this dismayed advocates for health equity like Kaiser Permanente concerned about the social determinants of health, as illustrated by the lack of public awareness of social determinants of health. The future of community benefit lies in adaptive, not just technical challenges for all stakeholders, regulators, hospitals, and communities. Now, I guess the next talk I'll go right ahead into. So if I could get to the first slide, I just want to again thank you for allowing me to share insights from specifically my practicum research. I performed a qualitative study of the history and current state of community benefit programs and policies in Massachusetts with the goal of making operational and policy recommendations for Washington State and other states. Once again, this was supported by the Commonwealth Funds conducted while at the Harvard School of Public Health under the auspices of Community Catalyst and does not represent the views of Group Health, Massachusetts Health System, or any other organization. Next slide. While in residency, a teaching attendee told me about his intern experience spending every other night in the hospital for a month. But then again, he probably had many of the same patients there that long too, getting low-intensity care we now would provide in a nursing home. That's a barest example of a revolution in hospital practices during the late 1970s and the 80s when federal policies changed the hospital market. Prospective payment eradicated unnecessarily long hospital stays. The charity obligations from the Hill-Burton Act described above mostly expired. Deregulation brought business sophistication to healthcare, but new patterns of thought as well. Hospitals closed, merged, or otherwise reformed, and some went too far. You can go to the next part. In 1985, the Utah Supreme Court revoked tax-exempt status for 2 Intermountain healthcare hospitals because they failed to advertise and spent less than 1% of revenue on their charity care programs. In 1990, the Texas Attorney General sued the nation's largest nonprofit hospital, Methodist, for using tax exemption to create a high-end hospital for the wealthy. With $2 million in $2 billion in gross revenue over 5 years and $250 million in profit, Methodist could afford Bellman, a health club, a gourmet restaurant, and a duck lodge, but only could afford $17 million in charity care. Texas became the first state to mandate that hospitals spend a fixed amount on charity care. In 1987, the board of the Catholic Health Association met in trepidation. You go to the next part, please. Watching on one hand the Hospital Corporation of America take over Catholic hospitals, and on the other hand watching restless agitation by tax authorities, the Catholic Health Association summoned consultants to help explain the unique role played by their hospitals. What they created, social accountability standards, evolved and were eventually adopted as the standard reporting format for the IRS. And if anyone wasn't paying attention by 1993, President Clinton's vision for health reform put everyone on notice. Next slide. Next slide. And the next part. A commission study of publicly available financial reports found that Boston's teaching hospitals were leveraging their tax exemption toward their own benefit, not for indigent care or other community benefits. In response, the Attorney General used his authority to summon hospitals to what he described later to me as a quote-unquote mini health reform summit. Doubtful he could win a legislative mandate, but exerting more tax authority than his Texan counterpart, he held over their head a sword of Damocles. They could remain untouched by the AG, but were advised to adopt voluntary guidelines he propagated in 1994 for hospitals and in 1996 for HMOs. If you can go to the next part of the slide, you'll see those guidelines. Massachusetts and Montana are the only states with voluntary reporting, but to the state government rather than to a state hospital association. Massachusetts also epitomized a process-focused approach to community benefit rather than a quantitative financial focus. Next, please. In 2001, a new Attorney General began a second policy phase for Massachusetts. Despite nearly universal acceptance of the AG's guidelines, reports could only be viewed by appointment in their office, had such variable formats as to, quote, often be impossible to interpret, unquote, and showed missed opportunities to share best practices and engage the wider community. Stakeholders worked through a difficult consensus process to develop a common reporting format. Oh, sorry, can you go to the next part, please? Which the AG in 2002 made mandatory if hospitals and HMOs volunteered to report their community benefit. Despite improved transparency, innovation, and spread of best practices, however, a new AG noted persistent problems in 2008 with collaboration and quality improvement processes. Despite universal health insurance in 2006 and 10 years of experience, hospital programs were still disjointed from larger health priorities. Next slide. Therefore, in 2008, Attorney General Marsha Coakley convened representatives from hospitals, health plans, consumer advocacy groups, academia, community health centers, and public health to revisit the guidelines. Structurally, the AG now required a mission statement and board and executive level oversight. Community involvement was expected in every stage of the process, particularly in conducting needs assessments every 3 years and in building implementation strategies. Rather than choosing programs without regards to priority populations, the AG limited the definition of community benefit to programs targeting identified vulnerable populations. Finally, hospital efforts must align with society-wide health priorities, which are listed next. Health reform, chronic illness, wellness of vulnerable populations, and health disparities. And next slide. The new guidelines attempted to balance regulation with innovation while focusing unambiguously on minorities and other identified vulnerable populations. These guidelines first applied to reports filed during my fellowship, which provided me a glimpse of their impact on current practice. Hospitals in Massachusetts will easily meet the ACA requirements if they fulfill state guidelines, although the long-term threat to the IRS is much greater. Next slide. For the IRS, hospitals will report how much they spent on each of the following categories, the option to report narrative details. First, community health improvement activities include health education and promotion programs, temporary community-based clinical services like cancer screenings, and wraparound services requiring a more sustained commitment, like addressing transportation challenges in rural areas. The Catholic Health Association in April offered its solution to the controversy around community building activities by advising hospitals to move some such activities to this section, community health improvements. Namely, the CHA advises activities that improve the health of individual persons as based on public health goals and/or the evidence to this section. Conversely, activities that build community capacity may be listed in their original section, as seen on the next slide. These are the 7 remaining categories, except for operational costs. The right panel is one example of a subsidized health service supported by the Sisters of Providence Health System, healthcare for the homeless, which I'll mention later. Next slide. Here you can read types of community building activities. On the left panel is a house that was bought by University of Massachusetts Hospital in order to raise home ownership in the Bell Hill community of Worcester. In that one neighborhood, you can find each of these community building activities being supported by UMass Hospital. One of my deepest impressions studying this topic was how thoroughly some hospitals abandoned their campuses and collaboratively strengthened their communities. Next slide. Of course, there are challenges, as best expressed by those I interviewed. Managers of hospital community benefit programs and an occasional VP. Our barriers will likely resemble these. First, inadequate funding for community benefit. Next, lack of measurement and evaluation expertise. Complexities of culturally competent outreach. A disinterested hospital culture. The varying capacity of community partners to work alongside hospitals, and the uncomfortable possibility for those of us in hospitals to shift away from random acts of kindness towards more organized and perhaps centralized approaches. And above all, the complexity of collaboration. For instance, in 2007, the Public Health Institute from Oakland, California, conducted a confidential evaluation of a Boston Academic Medical Center, which I did not research myself, but I had access to the evaluation. The reviewers noticed its programs lacked deep input from communities. They wrote, and I quote, "Less clear is the extent to which target communities of populations have been involved in program development. We know that a number of individuals were interviewed as part of the community needs assessment, but it is not clear how they were chosen or how the interview questions were framed. More transparency would be helpful in this regard." Community health at this institution was, quote, "a distant fourth to clinical excellence, teaching, and research," unquote. This should remind us of the African proverb, if you want to go fast, go alone. If you want to go far, go together. Next slide. There are successes for us to see and study and learn from. The smallest, least resourced hospital I visited successfully responded to a community need for fall prevention and smoking cessation education in schools. A screening van for cardiovascular disease at South Coast Hospital tracks adults and children year after year referring them to primary care as the need arises for things like high cholesterol and elevated BMI. Bay State Medical Center ensures access to care for poor children at their school-based health center. Two officials from Mercy Hospital show me a modern, clean shelter, which you saw in an earlier slide, offering food, housing, health care for homeless men and women in Springfield, and run similar programs in 46 shelters covering 1,800 square miles. Next slide. Partners Health System, the state's biggest employer, trains hospital leaders in health equity, supports community-based participatory research, and at the Brigham and Women's Hospital, works with 8 high schools to diversify the health and science professions. Next slide. And as I said before, the UMass Hospital supports just about everything in Worcester, including paying the salary of the city public health commissioner during tough times. Next slide. From the Massachusetts experience of community benefit, we conclude, state policies have become a tide that raise the boats of community benefit programs across Massachusetts, although hospitals naturally vary greatly based on what makes each unique: size, geography, wealth, academic affiliation, and most importantly, their mission and culture. Internally, hospitals have struggled to gain the core competencies required for community benefit. Even outstanding Harvard hospitals were described in an earlier stage in such terms as, quote, an academic center with community benefit hung outside, unquote. Let's not allow this to overshadow the innovation we can learn from Massachusetts hospitals and the significant potential of community benefit to leverage health improvements. Washington can also learn from possible missteps. Our hospitals would be wise to welcome public health involvement, not only in accumulating data, but in prioritizing interventions. Community-based organizations and policymakers must not assume that vulnerable communities will overcome what Bill Traynor describes as chronic disengagement without a functional civic infrastructures. Hospitals may now be destined to themselves help build that healthy infrastructure, namely through a collaborative process as integral to their own future as it is to those most vulnerable citizens entrusted to them by an increasingly watchful society. Finally, in the next slide, I would like to acknowledge the Commonwealth Funds, the fellowship run by Dr. Joan Reed, Jessica Curtis from Community Catalyst, the others, and in particular the community benefit staff at the hospitals, which I interviewed and not listed, but most important, my wife Matab and my daughter Marzieh for sticking with me through an entire year in Boston. And I'd like to leave you with the next slide, the last slide. Thank you very much.
Thank you very much, Dr. Thomas. Our next presenter is Dr. Megan Kay.
Great, thanks, Jen. So my role here at Public Health has been really to bridge public health with health care, and this is in line with the intentions of the Affordable Care Act. So I'm going to talk today about our collaboration locally on community health needs assessments and community benefit. When the IRS mandate for nonprofit hospitals to conduct community health needs assessments came out, Public Health saw this as an opportunity for collaboration with hospitals, not only on the community health needs assessment, but also on the implementation strategies. We saw this as an area where we could leverage limited resources and really avoid duplication of efforts. So together with WSHA, we brought hospitals together. And initially, we provided assistance by sharing data and resources on community health needs assessments. And I'll go through some of these with you in a minute. But this collaboration has expanded into an even more meaningful partnership, and I'll discuss that after I share the resources with you. In terms of community health needs assessment resources, there are many resources available. We put together a handout for our local hospitals in King County, and even since the time of putting that handout together, more resources have become available. But the ones that I've mentioned, that I've shown here on the slide, the Catholic Health Association has a great guide assessing and addressing community health needs. And it's a step-by-step guide that hospitals can use to conduct their needs assessments. NACCHO has also put together a nice guide on mobilizing for action through planning and partnerships. The community toolbox that I've listed there is a great database that you can search, just type in a search topic such as how to engage community or how to prioritize needs. And it will give you real-life examples as well as step-by-step instructions. The UK put together the National Institute for Clinical Excellence Health and Needs Assessment Guide, and this guide is also another step-by-step guide that can be used in addition to the Catholic Health Association guide. And then Alameda County in California has put together a handbook on their experience in participatory community health needs assessments, and that has been useful as well. So can I have the next slide, please? This is just a screenshot of the Catholic Health Association guide and where to find it online. If you just type that in to Google, this should come up, and you can download a draft version. They're kind of updating it, but it really incorporates information that pertains to the new IRS mandate. So I think hospitals locally have found that really useful in conducting their assessments. Can I have the next slide, please? So we are also working with the hospitals to discuss evidence-based strategies for their implementation plans. And in public health, we really do promote evidence-based strategies to address the community needs, or innovative programs like our local Global to Local initiative that have an evaluation component. So some of the resources that I've shown here they link to databases of promising practices or evidence-based strategies to address different needs. And I won't go through all of them right now because we don't have time for that. But if you haven't seen any of these, or if some of them are unfamiliar, I would really encourage you to look through them because they have a great amount of information that many of us have found really useful. Can I have the next slide, please? This is just a screen capture of the first resource that I had shown in the previous slide. And this is a great database put together by University of Wisconsin. And it links to their county health rankings model as well. But basically, if you decide that you want to do a program that focuses on tobacco or access to care, you can click into each of these different boxes, and then it will give you examples of strategies and projects that have been shown to be, through the evidence, that have been shown to be effective. Can I have the next slide, please? So the community health needs assessment and IRS mandated implementation plans that go with them are really an opportunity for collaboration, and hospitals can develop their needs assessments and strategies in collaboration with other hospitals, nonprofit and for-profit or government hospitals, as well as state and local agencies such as public health departments. Can I have the next slide, please? But the opportunity for collaboration really extends beyond just other hospitals and public health. Hospitals are really encouraged to engage community-based organizations, private businesses, academia, and community members as they develop their community implementation plans, so they can develop strategies that really will be received well by the community and have a better chance at success. We support advancing the state-of-the-art in community benefit principles, which really have an emphasis on disproportionate or unmet health-related needs, primary prevention, seamless continuum of care, building community capacity, and an emphasis on collaborative governance. And that was really our intention in bringing all the hospitals together. Next slide, please. So now I'm going to talk a little bit more in depth about our King County efforts to collaborate with hospitals on community benefit. The hospitals were convened by the Washington State Hospital Association and Public Health beginning in November of 2011. We also had individual meetings with hospital community benefit staff to assess their needs assessment process, the timeline that they had for getting this work done, the resources that they had available, any priorities that they had identified in the process, and their interest in collaborating with both public health as well as other hospitals in this effort. And all hospitals, nonprofit and even some of the private and district hospitals in King County, have shown a strong interest in collaborating with each other and with public health. So that's very exciting for us. Next slide, please. The areas for collaboration can be both on the community health needs assessment as well as the implementation plans. When we brought the hospitals together, many of the hospitals had already begun gathering their primary data, and they were moving pretty quickly forward, so gathering primary and secondary data. They did show a strong interest in the possibility of a countywide coordinated needs assessment in the future. But we decided that it was important to continue to move together forward on the implementation strategies for this year as well. Many of the hospitals have identified overlapping priorities because it's not surprising that they really serve similar communities. However, this first time collaborating together, there's been some interest in just selecting one or maybe two health priorities to address collaboratively, and then all of the hospitals would be responsible for addressing the other needs that they identify independently or in smaller groups. In our discussions so far, there's been a lot of interest in perhaps focusing on diabetes and obesity as areas that the hospitals would like to collaborate on this for this reporting year. Next slide, please. So when we think about collaborating, there's so many different ways that this could work, and I'm just going to go through 3 different models, and there are more in addition to these. But the first model, if we take diabetes as an example.
Welcome to GoToWebinar, web events made easy.
But implement them separately at their own will in their own hospital. So one hospital could have a diabetes support group, one could offer diabetes education classes, another hospital could have diabetes patient navigators. Next, please. Another model is all of the hospitals implementing the same program but independently at their own hospitals. So all of them could offer diabetes support groups that have culturally tailored classes and have the same model, but they would implement them independently at their own hospitals for their own patient community population. Next, please. And then the third model is that all of the hospitals could pool their resources into a community diabetes project, and hospitals and public health would all contribute to one project that would probably be based in the community. Next, please. So we have a lot of work ahead, and these next steps aren't listed in any particular order, but we need to work with the hospitals on what kind of model we would like to use for our collaboration and where on the disease spectrum we are going to intervene. Are we going to work at the disease level of patients with diabetes, or are we going to work further upstream on something like obesity and at the community, really at the community level? We also need to agree on what strategy we'd like to work on and how we're going to put that in place. Of course, we need to establish a timeline and goals, both short-term and long-term, and then just determine the resources that all of us are going to contribute to this process. And that's it for now. So this is an ongoing process, and I'm happy to answer any questions. I should have put my contact information on the slide, but I'm happy to talk with anyone who needs further information or anyone that we can help. My phone number, I'll just say it now so that any of you can that would like it can write it down. It's 206-263-8277. And my email address is Megan, MEAGAN.KAY kingcounty.gov. So feel free to contact me if I can be of any assistance. Thank you.
Thank you very much, Megan. And we will probably hold all questions to the end at this point, but I know most, if not all, of our speakers will be available to answer questions. Next up is Shalene Whitaker with the Washington State Hospital Association.
Thanks, Jennifer. So the Federal Affordable Care Act requires hospitals seeking to be recognized as 501c3 organizations to complete a community health needs assessment once every 3 years, and the needs assessment is also followed by an implementation strategy. And Washington State's hospitals are really just beginning down this road of collaboration, with the most recent needs assessments due to the IRS by the end of 2013 for most hospitals. So the Washington State Hospital Association is explicitly encouraging hospitals to work with their local public health department as the Federal Affordable Care Act calls out public health as a necessary partner in completion of these assessments. We have also met with Department of Health Secretary Mary Selecki on this topic and talked with her staff in terms of resources that are available. And in rural areas, critical access hospitals are also beginning collaborative conversations with their communities to explore transformation of rural healthcare delivery. And the community health needs assessments are really a key starting point for these conversations. So this slide is meant to show some of the collaborative efforts that are underway across the state. By no means is it meant to be a list of all of the conversations that are taking place and the work going on, but it's a sampling of some of the work between multiple hospitals in a community and public health, or in the case of Grays Harbor, a single community hospital working closely with public health. And the community health needs efforts right now are ranging from the case of Klickitat County, where the needs assessment is nearly complete, to the Pierce County effort that is really in its preliminary planning stages. So next slide, please. So the Hospital Association has information on our website specifically identifying local public health contacts and highlighting the new Community Health Needs Assessment law that Representative Laurie Jinkins will be covering here in a few minutes. And it also highlights some of the resources that Megan has presented to you today. And I want to thank the Washington State Department of Health and Seattle and King County Public Health for their help in creating these resources for hospitals. And so the message here is that the Hospital Association is encouraging hospitals to reach out to public health, and I want to echo that collaborative spirit here and really encourage public health to also reach out to your local hospitals if you haven't done so already. And if you are having trouble reaching your local hospital, my contact information is up here and on the slide, and WSHA is happy to help with providing this important link to public health. So if anyone has any questions, please feel free to email me or contact me. And I believe that is it for my slides today, but I'm happy to answer questions at the end of Representative Jinkins' presentation.
Thank you very much, Shalene. And Representative Jinkins, are you on the line now?
I am. Thank you.
Thank you.
Well, thanks for being patient with me. For those who don't know, I've worked a lot on marriage equality issues, and today was signature turn-in day, and I had a number of press interviews over the noon hour. So thanks for rearranging the schedule. I have kind of only a few things because my guess is people have been very thorough about the background, but I thought I'd talk to you about what motivated the community benefits bill that prime sponsored this last session. That is in gross substitute House Bill 2341, and then kind of what the path of that bill was and where we're at now with it. which I actually think Shalene did a good job of saying kind of where the hospitals are at in terms of engagement on it. You know, the legislative concern that really raised itself toward the end of the 2011 session and a lot more in the early 2012 session is there started to be some real concerns on behalf of legislators, including myself, that nonprofit hospitals in Washington are receiving some pretty extraordinary benefits, and legislators have started to question a little bit about what the community benefits are that are provided to communities as a result of the tax benefits that nonprofit hospitals get. So I spent a fair amount of time over the interim working on this issue, and I actually, the two people that I would thank most about this are my boss at the health department, Anthony Chen, who put me in touch with Dr. Thomas, who spoke earlier and who's done just extraordinary research on this topic. And I also worked with SOLFO and other folks in public health to talk through some of the issues that are raised by the Affordable Care Act and the fact that, or the presumption, I guess, that once it's really implemented, the amount of charity care that hospitals are going to have to give is going to go down dramatically. So how will hospitals invest in their community in a way that they haven't had to do in the past because they've had to invest so much money in charity care? Of course, that presumption, we'll have to see if that stays true. The end of the month, we'll see the Supreme Court case on the Affordable Care Act come out, and depending on what that court case holds, we all may have a lot of shifts that we have to make. So this, the bill started out fairly broad and with a lot of detail in it about what hospitals would need to do and in order to do their community health assessment and what they need to do in terms of an implementation plan. And it even did what some states have done, which was in a softer way than states like Texas and some others have done, but required some minimum level of investment. And so that was met, quite honestly, with not a lot of love by hospitals. And I do understand why, and I think the other challenge was that the more detailed and in-depth and prescriptive the bill was, I had to be very conscious during these tight budget times about how much it would cost the Department of Health to implement the bill. So with those kinds of two pieces of feedback, we started in one spot and then we ended up with a much slimmed down bill. But I think it's slimmed down in a way that moves us forward, and I think everybody involved, and the Hospital Association actually worked on this quite a bit with me, and we got to a place where we could all agree on it, which was great. You know, so it's now in a slimmed down version, but I think it'll allow us to start marching forward, and it'll allow the legislature to actually kind of take a look at what's happening and see if the guidance that the bill provides and that the Federal Affordable Care Act provides is enough to get us both the information and the kinds of community investments that we want. We can always go in and amend the bill and do additional things if we needed, but I think it's an okay and a good starting point. So the bill ends up with really, I guess I would say, 5 elements to it. The first is, you've talked a lot, others have talked a lot about the community needs assessment, and it requires that nonprofit hospitals make those needs assessments widely available to the public, and that as a part of the assessment they need to be able to provide some description of the community that they're serving, including the geography of the community and the population being served. They need to provide some demographic information like the leading causes of death and levels of chronic illness in the community, and a description of medically underserved people, including low-income folks, minorities, and folks with chronic illness. So it does have some requirements in terms of what the assessment needs to contain. But again, if you look at the first draft of the bill, much slimmed down from that. And then the other 3 elements really have to do more of the implementation plan. And the bill requires much more community engagement than the federal Affordable Care Act does in terms of the implementation plan. It does require that hospitals consult with community-based organizations and local health jurisdictions in their community, and then any other organizations that they wish to, but at a minimum those two consultations are required. And then the other thing that's interesting about the Affordable Care Act is it doesn't, while it requires that an implementation plan be done, it does not require that that hospitals really engage with community when deciding on what community benefits they want to implement, or that they choose things that the community would like. And this bill does require that if hospitals decide that they don't want to implement a piece of the implementation plan that is highly community supported, then they have to explain why that is. You know, and of course there can be very valid reasons for that. It could be that it's too expensive, or it's infeasible to implement, or something like that. So there are real reasons why that may happen. And then I thought the last point I would just make is my public health triumph in the end part of the bill is just that it requires that all of the implementation strategies be evidence-based. And if there isn't any evidence, that any kind of innovative program has to be supported by evaluation measures. And so that was, I guess, one of my strong public health beliefs as I looked at that, because again, when I go back to what I was hearing from legislators, there were frequently a lot of questions from legislators about whether or not some of the community benefits that are being implemented as actually marketing measures, and not really as interventions that are trying to improve community health. And so that's why legislators wanted evaluation measures. We started off without bipartisan support on the bill, but ended up with bipartisan support, and so now we're in an implementation phase, and it's been great to actually hear some of the reports about how much collaboration is going on between public health and hospitals and communities. So I'm happy to answer questions if anyone has them.
Thank you very much, Representative Jinkins. Betsy, would you mind letting people know how to ask questions?
That's fine. You can ask questions by typing them into the questions box, and we do have one that has come in so far, and that is, are other counties doing work similar to what was described in King County?
So Shalene covered that a bit in her presentation. I don't know, Shalene, if you want to highlight any additional examples.
I'm sorry, I had trouble hearing the question. Could Betsy please repeat the question?
Yes, it's, are counties doing similar work to what was described in King County? And if you could elaborate on what was your slides and what is being done.
Yeah, I will attempt to provide a little bit more detail. I'm involved in the work in King County, so I know that much more in detail. But I know that in Klickitat County, they've identified community needs and are working with their community members in terms of what organizations can address what need and what makes sense for the resources within the hospital. And that conversation is taking place within their county in a very thoughtful and strategic way. As I mentioned, Tacoma and Pierce County is really, they're in preliminary conversations in Vancouver and Portland. This is part of a larger collaborative that also includes the Portland area and some additional counties. So I think that they are more towards the preliminary identifying of the needs and next steps as well. So it's really, each county where this is occurring can be a little bit different. As far as the hospitals working to identify one community need that they want to focus on, I think that King County is the only one that I've heard of.
Thanks, Elaine.
Our next question is, how are hospitals and public health districts including or encouraging the inclusion of consumer stakeholder input in the design of the community health needs assessment?
Well, Jennifer, this is Shalene. I can take it.
Repeat the question. Okay.
Yes.
Go ahead, Shalene.
Oh, sorry.
Or Betsy. Either one.
Shalene, did you hear the question?
I think I did, yes. So I think the community collaboration and community input can be done in a variety of ways. I think the hospital is working on collecting input from primary data sources, so interviewing their community members. Again, I'll use Wichita County as an example. I know that they sent out a survey to their community and collected that in a variety of different ways, from at the county fair to interviews in person to different to mailing out information to folks. So that's how they were soliciting their feedback from their community. And I think it varies from, we've heard in King County that many groups have been meeting with different stakeholders, and some of them are realizing that they're meeting with those groups, maybe a week or two after the other hospital met with them. So I think there's a push for more collaboration, more communication around how those sources can be identified and provide less duplication in the future.
Thank you. Our next question is, what sort of thought has been put into how hospitals and public health will pay for the collaborative projects, and if they'll contribute equal resources or just the funding issues, given the overall funding issues in public health at the moment?
Shalene, do you want to take that one?
This is Laurie. I just wanted to, I don't actually have an exact answer to that, but I do want to note that in the early draft of my bill, and it's something that I'm certainly still happy to do, it just didn't end up in the final version, was to at least indicate that any money that hospitals invest in doing their community health assessment and their implementation plan can be counted as a community benefit. So I was hoping that that might incentivize, some of the investments in collaborating with public health on that in terms of getting data and things like that. Again, it didn't end up in the final bill, but if it's something that it seems like we're going to need to do in the end to help help with some of the funding issues, if that will help, then that'll be something I'll definitely be willing to work on.
May I add to that?
Yes.
Also, in the ACA, I think there is also a collaboration budget, so to speak. You can count your community benefit organizational costs towards how much you actually spend, and that's actually reportable. So any money that the hospitals actually spend to create a collaborative process counts as community benefit as well. It's under Section G in the CHA guidelines, and it's also in the IRS Form 990.
Okay, our next question is, what % of health systems' annual net revenue is required for this community investment?
Betsy, what was that? What percentage of what revenue?
Health system, a health system's annual net revenue is required for the community investment.
So the Affordable Care Act did not provide a minimum level, or did not set a minimum level for hospitals or health systems, nor did the state law. And I think Dr. Thomas pointed out earlier that this is a social contract between hospitals and the public and government entities around how much community benefit they are providing. And this is all publicly reported now through the Internal Revenue Service, and as Dr. Thomas described, there are a variety of categories that are listed in that IRS form.
And finally, our last is not a question.
This is Laurie. I would just note that the early version of the bill of my bill required one of three ways to look at it: a level that's reasonable in relation to the community needs defined in the assessment, or an amount that's at least 100% of the hospital's tax-exempt benefits, or an amount that's equal to at least 5% of the hospital's net patient revenue. So that's where I started in the bill. None of that ended up in the bill. And I think this is one of those topic areas that we really have to see, as Dr. Thomas said, what does the social contract look like? And you know, if it appears that there's not enough investment happening, this may be a push in the future. But I think we've decided, at least the legislature decided, rather than putting in a minimum level of benefits, let's kind of see how they stabilize out and then see what we need to do, if anything.
Okay, our next question is, in my community, the two large hospital systems are competitive in many areas. Realistically, how do we bring hospital systems to real collaboration instead of competing for funding sources and patients?
Well, this is Shalene. I think, I don't know what community this person is describing. It would be helpful to find out. I think, for example, I know Multi-Care and Franciscan in Representative Jinkins and in Representative Jinkins' district are fierce competitors, and they're in the room together wanting to identify the needs of their community together. Same with the King County Hospital. I mean, Seattle area is known for some of the most fierce competition in the state, and the hospitals are all at the table together. So they're setting aside their competitive differences and are able to see how collaborative efforts can reduce duplication. And also, I think I'll just point out that depending what community you are in, I mean, the for-profit hospital, if it's a for-profit hospital in your community, is not required by the IRS to do this. It's something that I would hope that the hospital would be willing to do and might want to start a conversation. But there's also, I think, that point to keep in mind about who this law targets. And again, I'm happy to help facilitate some of those conversations. If someone is interested, they can contact me and let me know the hospitals that they're talking about directly.
If anyone has any additional questions for Representative Jinkins, could you please submit them now?
I was just going to note one other thing. The other kind of hospital that we have in Washington and mostly around the country, of course, are public hospital districts. And I don't think the ACA, this portion of the ACA, applies to public hospital districts either. Nor does my bill. The first draft of the bill did. But again, as we slimmed it down, it now applies only to nonprofit hospitals.
Yeah, that's a great point, Jenkins. This is Shalene again. And I will point out that some of the public hospital districts do seek to be recognized as 501c3 organizations, and the IRS guidance applies to them. So and that's an individual hospital by hospital decision. So some of the public hospital districts may need to be complying with federal law as well.
Well, it appears that that is it for our questions today. I do have one comment that was submitted, that is that the Chelan County hospitals and other partners, including public health, are actually meeting this afternoon to work on this process. If there are no...
Thank you, Betsy. Thank you very much to all of our presenters today as well. A lot of information was covered, and it will be available online.
It was a pleasure to participate.
Thank you for joining us, and our next webinar will be on July 11th and will address the agenda for change.